welcome to the online course on Managed TB. My name is Dr. Manoj Murekar and the topic of my talk is TB, a global public health problem. Well, this is the outline of my talk. I am first going to talk about the burden of TB at global as well as national level. I will then talk about why TB is a serious health challenge, and then I will talk about WHO's End TB strategy. Well, we observe 24th March as World TB Day. On 24 March 1882, Dr. Robert Koch first announced to the Berlin Physiological Society that he had discovered the cause of TB. In 1884, he published a paper wherein he explained his observation, which since then are known as Koch's postulates. Since the discovery of etiological agent, there have been a number of technological advances both in the diagnosis as well as treatment of TB. Despite this, TB continues to be one of the leading causes of death globally. As per the World TB Report 2021, in 2020, TB was the second leading cause of death from a single infectious disease, the first being COVID-19. It was estimated that there were about 10 million incident TB cases and around 1.25 million HIV negative TB patients died. TB cases were reported from all countries with wide variation in the incidence. The incidence varied from less than 5 to more than 500 new and relapse cases per 100,000 population per year. This slide shows the burden of TB in different regions. Around 70% of TB cases were from Southeast Asia and the African region. Nearly 65% of the estimated global TB cases were from 8 countries, with India contributing to 26% of the global burden. In India, an estimated 2.6 million cases of TB occurred during 2020, with an incidence rate of 188 cases per 100,000 population. Nearly 2% of these cases were multi-drug or rifampicin TB resistant cases. TB also is an important cause of death in India, with a mortality rate of 36 per 100,000 population. Having told about the burden of TB, I will now talk about why TB is a public health challenge. Let me first talk about the risk factors for TB. As we all know, TB is transmitted from an infected person to a susceptible individual through air. When pulmonary TB patient coughs or sneezes, infectious droplet nuclei are generated, and these droplet nuclei remain suspended in air for several hours. When a susceptible person breathes these droplet nuclei, they get infected with TB. This slide describes some of the important risk factors for TB. This includes host factors such as proximity with infectious case, younger age, HIV infection, malnutrition, and diabetes. Important environmental and social factors include crowding, poor ventilation, indoor air pollution, alcohol, and smoking. Epidemiological studies conducted during mid-20th century have shown that the smear positive cases are more infectious than others. An untreated sputum positive patient can infect approximately 10 individuals per year, and each smear positive case can lead to 2 new cases of TB, at least one of which will be infectious. The concentration of TB bacilli in the sputum of TB case is positively correlated with infectivity of the patient. Studies also have found that the odds of TST positivity for contacts were higher if the index case had a higher number of TB bacilli in his sputum. Proximity with infectious case is another important host factor. Close contacts of infectious TB case, including household contacts as well as healthcare workers, are at higher risk of becoming infected with MTB as well as developing TB disease. This has been the scientific basis of contact screening. In most TB control programs, contacts of sputum positive cases are screened for active disease. We also need to understand that casual contact is an important factor, especially in endemic settings. The importance of casual contact was noted in early epidemiological studies, which showed that majority of older children with a positive TST result reported no household contact with a source case and were therefore likely to have been infected in the community. In a study conducted in South India, of the total persons infected in the community, only 2% belong to case household, whereas 7% belong to suspect case household, and the remaining 91% of the cases belong to non-case household. Coming to the next risk factor, that is immunosuppressive conditions. HIV co-infection is the most potent immunosuppressive risk factor for developing active TB disease. In the six southern African countries where adult HIV prevalence is high, more than 20%, the estimated case notification, TB case notification rates also are very high, ranging between 460 to 700 per 100,000 per year. HIV co-infection greatly increases the chances of reactivation of latent TB infection and increases the rapid progression following primary infection or reinfection with TB. HIV co-infection exacerbates the severity of TB disease and increases the rate of disease progression and therefore mortality. Malnutrition is another important risk factor for TB. Malnutrition increases risk of TB mainly because of impaired immune response. TB disease can cause malnutrition because of decreased appetite in TB patient as well as changes in the metabolic process. To address the issue of malnutrition among TB patients, Government of India has started a scheme called Nikshay Poshan Yojana, which involves providing financial support to TB patients towards nutrition supplementation. And this scheme is applicable to patients who are undergoing TB treatment. Compared to adults, children are at higher risk of acquiring TB infection as well as TB disease. Most children less than 2 years of age get infected from household source case, whereas with children more than 2 years, the majority of them become infected in the community. Among children less than 2 years of age, the infected population is relatively small, but disease incidence is exceptionally high and frequently take the form of either TB meningitis or miliary tuberculosis. And hence the mortality due to TB is very high among children aged less than 2 years. These findings have provided a scientific basis for classical contact investigation practices, which in most developing countries focus on younger children. And as I mentioned earlier, India's national TB program recommends screening of household contacts of all sputum positive TB patients and 6 months of INH preventive therapy or IPT for asymptomatic children who are aged less than 6 years. Diabetes is another major risk factors for TB. A systematic review examining the association between diabetes and TB found that diabetic patients have about threefold increased risk of developing TB when compared with those without diabetes. Studies have also found poorer outcomes of TB disease among diabetic patients. We know that about 70% of people with diabetes lives in lower middle income countries. The prevalence of diabetes in India is on the rise, and this could pose a challenge for TB control in the future. Having told about the risk factors related to the individual, let me now talk about some of the important environmental as well as social factors. The developing countries are witnessing rapid urbanization, and people with low socioeconomic status residing in urban areas are exposed to several risk factors, including crowding, poor ventilation, and indoor pollution due to burning of solid fuels. The rates of malnutrition as well as smoking and alcohol use are high in such communities, which increases the risk of TB in this population. The association between smoking and TB has been studied in several systematic reviews, and these studies have consistently shown a higher risk of TB among smokers in comparison to non-smokers. There is a clear evidence that smoking is an important risk factor for both TB infection as well as TB disease. Smokers are also at higher risk of death due to TB. Alcohol use is another strong risk factor for TB disease. The risk of active TB is about 3 times higher among people who drink more than 40 grams of alcohol per day or those who have alcohol use disorder. This table summarizes the relative risk of important risk factors associated with TB disease. The population level impact of this risk factor depends on first on relative risk as well as prevalence of this risk factor in the community. The population attributable fraction, that is the proportion of TB cases that could be attributable to a specific risk factor, is provided in the third column. As you can see, interventions targeting malnutrition, targeting indoor air pollution, smoking, and alcohol consumption would have a higher impact on TB burden. Let me now talk about some of the health system factors influencing TB control. As per the World TB report, it was estimated that about 10 million people developed TB in 2019. Yet 2.9 million cases were not notified to national TB programs. Missing TB cases is an important issue for most TB control programs. So why TB patients are missed? This could be due to underdeveloped health reporting systems and insufficient human resources. Several countries also do not have a mandatory case notification, or if it is there, it is not enforced strictly. The second important reason is the access to health services, especially among vulnerable populations. This also leads to delay in diagnosis as well as treatment of TB patients. Studies have estimated a delay of about 2 months between onset of TB symptoms, start of treatment in many LMICs. In many countries where there is a large private sector, TB cases which are detected are often underreported due to poor linkages between private sector as well as national TB programs. Treatment of TB is complex and involves different drug regimes. The duration of treatment is also long, ranging from 6 months for drug susceptible TB to more than 1.5 years for drug resistant TB. The second line drugs used to treat drug resistant TB are toxic. These factors could in fact influence treatment adherence. Failure to adhere to treatment could result in resistant strains, and the management of drug resistant TB is another important challenge for TB control programs. As per the World TB report, globally around 2 to 4% of people diagnosed with TB for the first time, and about 18 to 21% of patients previously treated for TB were rifampicin or multi-drug resistant. In 2014, the World Health Assembly adopted End TB strategy and pledged to implement it. The strategy has 3 indicators. First is to reduce the global TB deaths by 95% compared with the 2015 figures. Second is to reduce the TB incidence rate by 90% compared to 2015. And third indicator is to ensure none of the TB affected families face catastrophic cost due to TB. The End TB strategy has 3 pillars. The first pillar of the strategy is integrated, patient-centered care and prevention. This includes early diagnosis and systematic screening of contacts, treatment of all TB cases, including drug resistant TB cases, preventive treatment of persons at high risk, collaborative TB HIV activities, and management of comorbidities. The second pillar is bold policies and supportive systems through strong political commitment and engaging communities and public and private providers. And the third pillar is intensified research and innovation. Government of India has set a very ambitious target of TB elimination by 2025. The National Strategic Plan was prepared to provide a framework to guide key stakeholders, including the national as well as state governments, private sector, as well as international agencies. NHP has four strategic pillars, that is detect, treat, prevent, and build. Detection includes finding all DSTB and DRTB cases, reaching TB patients seeking care from private providers and undiagnosed TB in high risk populations and their appropriate treatment. The third pillar is about prevention and prevention of emergence of TB in susceptible population. And the fourth pillar is about building and strengthening enabling policies and ensuring financial resources to match these plans. The last 2 years of the COVID-19 pandemic have reversed the progress made in TB control. The most significant impact of COVID pandemic and the disruption in health services because of the pandemic was a big drop in the number of people newly diagnosed with TB. The TB notification in 2020 has reduced by 18% as compared to 2019. And 16 countries contributed most to the global drop in TB notification, with India alone accounting for about 40% of the share. Another impact of the pandemic was increase in TB death in 2020 as compared to 2019. This table summarizes the impact of the pandemic on TB services. As you can see, the TB notification rate declined back to the level which was there in 2012. The estimated TB deaths and number of DRTB patients treated were back to the level of 2017. There also was a fall in global spending on TB, on diagnostics, on treatment, as well as preventive services. The progress towards TB milestone and the targets in India as well as most TB endemic countries is off track, and every country therefore needs to urgently initiate appropriate actions to mitigate and reverse the impact of COVID-19 pandemic and accelerate the progress towards end TB targets. Thank you.